This is a fairly hefty topic to try and cover in 20 minutes. I'm not going to provide all of the answers and all of the solutions, but what I will share is a bit of how BD and industry can help, and I think we're going to turn to Claire shortly, who's going to give you a more concrete example of delivering practice change and better outcomes at the Royal Berks Hospital. So, before I get into who BD is, and I'm the conversations I've had on the stand out there is most people don't know who BD is or what we do, so an opportune moment to share some of that is, I think one of the largest untapped resources available to you all to help affect change, practice, training, and so on is actually industry. And I think I would ask everyone here and your colleagues to frankly demand more of industry to help you deliver the outcomes you're looking to see. We're not just providers of kit and products. I think we can help genuinely affect change in practice and behaviour on the ground, and I think that will all help deliver the safety improvements you look to see. So, BD as an organisation, mostly unknown, but we sell into healthcare services around 27,000 different product lines currently in the UK. You use about 1.1 billion different product items from BD each year. So there really aren't patients out there who go through the health system, whether it be at home, in hospital and through that care in hospital, or back out to home or hospice. Pretty much everyone gets exposed to something from BD at some point. But we started about 120 years ago with the first glass insulin syringe, and from there have grown into this kind of 27,000 product organisation. BD, in case you're wondering what BD stands for, is Becton Dickinson, but that has amalgamated Care Fusion and Bard Healthcare into that fold, and for good reason. What it's allowed us to do is really to connect up a lot of the different health products and systems that you will utilise across the journey the patient goes through. So whether it be improving the collection of blood or urinary samples, whether it's improving the diagnostics and the time to diagnosis and treatment, or whether it's through to improving the medication preparation, the compounding and pharmacy, and that ultimate administration, be it through a smart infusion pump or directly injected. We can make a very real difference by joining all these different elements up. So, outside of here and now, if you do want to chat later, if you've got an interest in reducing medication errors, speeding diagnostics, or reducing the numbers of central line, peripheral line, urinary, catheter-related infections, then come and talk to us. What I wanted to chat about, though, was ultimately not the broad range of products that we do, but actually the wraparound support that comes with those products. So there is a huge number of people within BD and more widely industry who can be called on to train staff. And for all of our great products, if they're not used correctly or you don't have the safety systems turned on and implemented, then you're never going to get the safer outcomes you're seeking. So that's back to the kind of demand more from us. So we've got people. We also have other things we do with healthcare partners, staff in the community, or in the acute setting, where it relies on you coming to us and saying, look, we need help. And just as an example, the Hamilton University Hospitals Trust, a lady called Sepsis Maggie, who has now moved on to King's College Hospital A&E unit. Sepsis Maggie is not a super spreader in the current parliament. She was just passionate about tackling sepsis and getting patients identified and the appropriate treatment delivered. But she had a team who were running around with kind of paper-based reminder cards in their pockets that were getting dog-eared, out of date very quickly, and wanted to find a way of improving on that. And we worked together to develop an app, not with Piotr, but I have spoken to James and he can do all of this for you, to develop an app that put the, not just information related to sepsis, but all the relevant, important safety information, protocols, guidelines, steps their staff need to take in the hands of the healthcare professional at the bedside, and actually found it quite an engaging tool to connect them and their patients, and reassuring for the staff, reassuring for the patient, everyone's taking the right steps. And it's rapidly updatable, and it's now used by hundreds, if not thousands, of staff at the Homerton, and used daily and weekly by many of them to make sure they're doing the right things in the right way. One example, at I guess a local level, a more grander example, and this is perhaps an illustration of maybe $1 billion is invested by BD worldwide in research and development and collaborative working projects. And this is just one of the more global ones, the Antimicrobial Resistance Fighting Coalition. A bit of a mouthful. The website, if you can see it down the bottom, if you want to register, do. But this is a broad global coalition of bringing together medtech, pharmaceutical companies, government, healthcare professionals, all sorts of stakeholders and organizations to try and tackle a difficult subject that can only really be tackled through broad collaborations and collective working. So, 2 examples. We've got great products, we've got amazing people, and I don't just mean our clinical staff. Things like the Homerton app relied very heavily on creative and other departments that exist within large organizations that you can lean on to help you pursue what you want to. So, BD, very keen to share the responsibility. I believe we have, it's the onus is on us as well. If you can challenge us to do more, to improve safety and efficiency. What I'd like to do is hand over to Claire now, who's actually going to talk about a bit more closer working and collaboration at ground level in a local hospital. So Claire.
Thank you, Simon. I'm also known as Septic Claire, so I'm Sepsis Maggie's counterpart, but in Berkshire, so we do get around. I have a disclaimer, actually, to begin with. I don't have a bit of kit to share with you. I don't have a magic button or a pill or anything to share, because as we know with a culture of safety, much like sepsis, it's very, very complex. There's lots of questions. We can't scan sepsis, we can't palpate it, we can't use a blood test as much as the media outlets would like us to believe there's a sepsis level in the blood. It's just not the case. So it's a very, very complex area, and there's no easy solution. Now, there's no single one-size-fits-all when it comes to sepsis, and actually our patients with sepsis are presenting all day and all night, and they're presenting to all manner of healthcare professionals. This diagram here is looking at actually how patients come into my hospital, how patients get to my A&E. There's 8 points of contact before they even set foot in A&E. They're meeting, they're talking to people in a number of different places. And actually, as healthcare professionals, it's our responsibility to be supporting our patients, but also supporting our staff throughout every single moment of that journey. Often, the patient's first point of contact is with someone who has very little medical experience. They may be on the end of a phone, they may not be able to see that patient. And actually, we know there is a clinical need for improved care in sepsis, and actually there's a need for improved safety culture when it comes to sepsis. We do lots of this work all the time. For those of you who work in primary care and secondary care, we're constantly evaluating the work that we do. A timeline, I call this my level 4 timeline. It has the buzzwords that our execs like to hear. It has compliance, it has working groups, quality improvement strategies, and trust policies. It has all of these things involved in. But actually, what does that mean when it comes to a safety culture and us working? Well, back in 2017 to 19, there was a national sepsis sequence that I'm sure lots of you are familiar with. At the RBH, we decided to embrace some innovation, to develop an electronic sepsis screening tool, and therefore develop a huge database of septic patients who came into our trust, were treated, and then left our trust. And actually what that did, as many innovations do, is it led us to have a look at some areas we weren't particularly good at. As well as embracing the things that we did really well, there are some areas for improvement. Now, I'm talking about safety culture, but actually I'm also going to be talking about blood cultures. And blood culture is a specific area within our trust that we knew we needed to improve. In April 2019, we thought, right, we need to be doing something about this. We identified this as a quality priority for our trust, and we formed a working group. A working group which had clinicians, it had nurses, doctors, healthcare assistants. Because in my trust, who does the blood cultures? It's our Band 5 nurses and our healthcare assistants. Whilst it's great to have experts and policymakers, actually, if that information isn't being fed back down to our clinical staff, is it going to be of the most value it could be? We joined at this point with our colleagues in BD to say, look, what can you do to help us? We are all overworked, and actually we're overwhelmed by the amount that we need to be doing to care, not just for our septic patients, but for our whole patient population. We audited, because that's what we do. We identify a problem, we form a group, and we audit, don't we? So we audited, and from that audit came a 52-page policy about blood cultures. Did that immediately send our compliance rates up? No, it didn't. I went to speak to the staff in A&E, and I said, look, we've written you a policy. It's 52 pages, it's great, it's got loads of information in it. And I communicated at you. I told you about this policy. And they said, but you haven't communicated with us. Great, there's a policy. When am I going to read a 52-page policy? I work in A&E. I'm lucky if I get a 20-minute break. So, check for me. Okay, I need to start communicating with my staff, not just at them. And when I asked my staff, well, why don't you do blood cultures? What is it that's stopping you? Is it that we don't have enough bottles? Is it that we can't get the blood from these patients? And one of our healthcare assistants said to me, he said, I forget. I said, well, why do you forget? I refer back to my 52-page policy. This is a really big deal. And he said, because it doesn't affect me. I take blood cultures in A&E, and I send them to the lab, and I never hear of it again. These blood cultures may take a day, 2 days, 5 days to come back. By then, this patient is on another ward, they're having some other investigation, and I've seen potentially another 300, 400, 500 patients since then. So actually understanding their limitations and communicating not just at, but with our staff started the ball rolling when it came to some change that was going to be sustained. So we put our thinking caps on, we went and spoke to our colleagues at BD, and we said, we need an overview, because at the moment we are blinkered. We have so much to do, we're completely overwhelmed. Our colleagues at BD were able to come in. They actually just observed. They watched what we were doing. They didn't say anything, they just watched our practice, the patients that we were picking to do blood cultures on, and then some toing and froing, a few more workshops, and we came up with a number of quality improvement strategies for our entire sepsis program. This is just one example talking about our blood cultures. So we knew we wanted to minimize the time that it takes to effective treatment for sepsis. We knew that we wanted to optimize the diagnostic accuracy of the tests that we were doing. And actually, then we wanted to minimize the use of ineffective antibiotic therapy with our antimicrobial resistance hats on, looking into the future. So we needed to bring our staff into this and actually get their buy-in. Now, one of the incredibly simple things we did was a communication loop between our microbiology labs and our A&E staff. So if we have a positive blood culture result, that is fed back to the Band 5 nurse who took those bloods at 4 o'clock on a Saturday morning, and it says, look, this is what you found in your blood test, and this is what happened to that patient. This patient had their antibiotics changed. They went home after 5 days. Thank you very much for all your hard work. Has that sent our blood culture compliance rates up? Absolutely. So a combination of education, policy change, and communication strategies has started to increase our blood culture compliance from less than 40% in our sepsis cases to now upwards of 80% within a very, very short time frame. So this is just one very, very small snapshot of the work that we're doing, but actually our reliance not just on our own staff, but bringing in partners such as BD, bringing in industrial companies to help us, I think is going to help a sustainable change for the future.